Can you see that okay?
Yep.
Does that work?
Can everybody see the presentation?
Okay.
Yep.
All right. Oh, shoot, you're muted. Sorry. There you go.
You should be able to hear me now.
Yep.
And are we recording, Jack?
Yes, we are.
Okay, great. Sorry about that.
Okay. Good afternoon, everybody. I am Ashley. I'm a nurse practitioner with palliative medicine over at LMH. And along with Debbie today, we're going to go over understanding hospice and palliative care. And we'll have some question breaks here and there, so please keep those in mind, and we will get to those. And I'm ready for the next slide. There is our beautiful pictures. A little bit about us. So palliative care, understanding palliative care. World Health Organization defines palliative care as the prevention and relief of suffering of adult and pediatric patients and their families facing the problems associated with life-threatening illness. These problems include physical, psychological, social, and spiritual suffering of patients as well as their family. Next slide, please. What is palliative care? Palliative care is a big hug when things are stressful, just like that. It's an extra layer of support wrapping around you. Care that focuses to make everyday life better, like relieving pain, helping reduce breathlessness or nausea, while supporting people and their loved ones through the anxiety of living with a serious condition or illness and making practical plans for the future. Next slide, please. So this is a little bit about the history of palliative care, because everybody.
Oops. You need to unmute again.
Thank you. Sorry, I hit the button. I get this a lot. What is palliative care? So in 1967, this lady named Dr. Saunders, I should say, is thought to be responsible for establishing the discipline and culture of palliative care. She introduced the idea of total pain, which included the physical, emotional, social, and spiritual dimensions of distress and treating those. She was responsible for establishing, like I said, the discipline and culture of palliative care. She introduced effective pain management and insisted that dying people needed dignity, compassion, and respect. She actively worked on abolishing and prevailing ethic that patients should be cured, or patients should be cured, and those who could not be cured were a sign of failure. So that was kind of the thought of that time. If we weren't able to cure this person, then we're failing. So she was trying to work on really focusing on, the comfort if a cure could not be found or had. Moving on, 1974.
Sorry, I messed up.
Oh, I'm sorry.
No, that was my fault. That was my fault. There we go.
It's kind of, we can kind of go through this, this lady traveled to listen to one of Dr. Saunders' lectures, and she brought the concept back to the United States, where most hospices were home-based and volunteer-led at that time. Jumping forward a few decades, we started to have more studies in how palliative care really supports and shows that it actually helps people live longer, better lives with palliative care in their medical team, I guess, in their care, and providing them that additional support and symptom management. They live better, longer lives with and without. There's been many studies done since then, and palliative care has evolved over the years. The specialty is becoming more recognized and understood, which is great. We still have some room to grow, and we work toward reaching people that would benefit the most from the extra support while navigating life-limiting or advanced illness. Okay, now I'm ready to go to the next slide, I think. What is palliative care? The #1 question, and I'm sure you have that on your list today. It is another piece of your healthcare system, and it's specialized medical care for people living with serious illness. And I know a lot of this is repetitive, but you'd be surprised at how many people, even, you know, in the medical field, that don't quite understand what we do, and that's okay. That's why we do these talks and this education. Going down the slide, palliative care is meant to enhance a person's current care by focusing on improving the quality of life for both patient and their loved ones. Focusing on helping patients live as well as possible with their serious illness for as long as possible. And it is appropriate at any age or stage of serious illness. The earlier we can get on when a serious illness is diagnosed, the better. So we can just start having those conversations and follow along with the progression of the illness and curative treatment. One thing I want to talk about on this slide is that, like I touched on before, when I walk into a room and say I am here as the palliative care nurse practitioner, everybody kind of will do this and say, oh my, did somebody forget to tell me that I'm at end of life? And that happens a lot, more than you would probably think. And, you know, it's just that taking that time to tell them, hey, we're here to help. We're here to address some of your symptoms that are related to your illness that could help you have better days. And that's what our goal is, to follow your goals for your healthcare, but also allow you to have better days within this, within your illness. More good days than bad, I should say. So that's kind of, I'm reading my notes here. That's kind of my day-to-day. I will go in and care for a patient in the hospital or in the outpatient setting. We do both. And each day could be different. You know, they could come to me and say, oh, I'm having a bad day. This is what is going on. It may be related to symptoms. It may be related to just, just things that are going on in the house, that, my granddaughter's sick, or my dog I had to take to the vet, or same things like that. And we just sit there and talk about it. So, not every visit is just related about symptom management. It's just, going through life and talking through things and providing that extra support as well. Another thing, palliative care focuses on easing pain and discomfort, and helping people have the highest quality of life possible while receiving those supportive treatments. That's really the difference between hospice and palliative care. Palliative care is the symptom management and extra support while you're still receiving treatment and seeing your regular doctors. We work alongside those other doctors. And then hospice is when the care focuses on quality of life, when cure is no longer possible or the burdens of treatment outweigh the benefits, which we'll talk more about later on in the presentation. Next slide, please. Who would benefit? This is not an all-inclusive list, just an example of patients that we may see or support. Okay, thanks. Patients with cancer, advanced heart disease or failure, advanced dementia or Alzheimer's disease, lung diseases like COPD, end-stage kidney diseases like people on hemodialysis, liver disease, cirrhosis is a common one, neurological diseases such as ALS or Lou Gehrig's, anybody that's had a stroke that's debilitating, Parkinson's disease, Huntington's disease. But in all, support for anyone who has an illness or illnesses that impacts their daily lives. Another option is, patients that are on oxygen. They may have COPD, but it may not be like an end stage. They may just be on oxygen, and they may have, a hard time completing their daily life, like activities like bathing or getting dressed, or, doing errands or preparing meals. And that's the kind of things we really talk about when we get into a visit. Like, are you able to do those things? And if not, how can we help you? Whether it's physical or whether it's just being short of breath, or you need a little physical therapy to get a little stronger, or just some things like that. I'll go to the next slide, please. How can palliative care help? Well, we assist with pain and symptom management, like we've reviewed before. This can include nausea, poor appetite, fatigue, pain, constipation, diarrhea, shortness of breath, anxiety, debility, or weakness. We have serious illness conversations, so kind of help with patient family understanding of the illness and treatment options, and what to expect as disease progresses, or prognosis. Kind of questions like, what does my diagnosis mean for me now or in the near or distant future? How is my illness, disease impacting my quality of life? We can also assist in identifying goals for living and what is acceptable or unacceptable quality of life, or what that looks like to you and what that means to you. So some questions that I hear I would ask, like, what are your goals for your healthcare? Or, we talk about code status, which is for resuscitation, or treatments that I wouldn't want if it came down to some sort of illness, like would I want tube feedings, or, the ventilator, or things like that. We talk through those things. How will this affect my loved ones? Or what additional support might I need and when? Or what is most important to me? Some things we talk about. Another thing is advanced directives. And these are those papers that you fill out saying, okay, if I wasn't able to make decisions for my healthcare, who would make decisions for me? That is called a durable power of attorney for healthcare. We, can help with those. It's very important to have those in place and talk with your wishes to that particular person, because they are who makes your decisions for you. If you would come into the hospital and not be able to tell us what your decisions would be in certain situations. A living will for healthcare, which kind of goes over, what you would and wouldn't want for treatments. And we talk through patient and family education. So like talking through the illness or disease itself, what does that mean? And how does it impact my family or my lifestyle? And kind of how to navigate the health system and family and work, all while I'm going through, say, treatments for cancer. And then also family meetings. We will set up family meetings when we need to talk through those things. Say, there's a big decision that needs to be made, or there's maybe some not so good news, and we need to make a decision whether, I'd want to be okay with going through this type of treatment or a path, or I want to focus on something else, and talk about, kind of what those paths look like from here. And, what may things look like from 3 months from now or a year from now. We can just kind of talk about that with your family or your loved ones. To kind of just help facilitate those discussions, because they can be hard. Next slide, please. Palliative care is so much more. Focus on quality of life is really a big one. And even in, death as well. We view death as a natural part of life. Palliative care is a lessening and relief of physical, psychosocial, and spiritual suffering, so that patients can accomplish his or her goals and life closure tasks. Closure tasks may include saying goodbye, letting go, finding meaning and value in life and death, and mending relationships. Control and management of physical, emotional, psychosocial and spiritual pain and suffering and other end-of-life issues are paramount. Helping patients have more good days than bad. Determining specific things that bring you joy and quality of life to each patient, and helping you to continue to do those things that bring you joy for as long as you can. Also, just kind of what goals do you have? Is it your goal to get to a race or an event a few months from now out of state, and how can we accomplish that? How can we help you get there? Things like that. Each of our patients that are under our care are different in many ways. Each have their own goals of living, views on life and death, things that bring them joy, or goals or tasks that they want to accomplish yet. So everybody's individual, and we talk through those things and try to continue that as long as we can. The next slide is more of a graphic, and not so much to focus on the little boxes, more of the big long thing at the bottom. This is from KU, Palliative Care Services. They made this little picture here, and one can see that the life prolonging therapy and where palliative care begins there with the green. This is kind of what palliative care and hospice, and then look at the end is death, bereavement. This kind of gives you a little bit of a visual how palliative care works alongside your regular doctor care, and then kind of where hospice falls in. When supportive measures are no longer working or no longer desired, and you want to focus just on quality of life, on comfort, not go back and forth to the hospital. And that's kind of where hospice takes over then from palliative care. And we help with those discussions if and when and you'd want to elect hospice care at that point. And we work towards that when you're ready. Some patients, are there quicker depending on the disease. Some, are not, and follow us in palliative care for many years. While hospice falls under the umbrella of palliative care can be provided, of course, from the time of diagnosis to serious illness and concurrently with curative or life-prolonging treatments. And we will get to that here in a minute with Debbie. The next slide, please. Where can palliative services take place? Over at LMH, we have inpatient and hospital settings. So, if you come into the hospital and you've seen us on the outpatient side, we will follow you for additional support because we kind of know you. We know what medications you're on for comfort, if we are managing those. And we also kind of know, your history, your support system outside the hospital, and really can kind of help the hospitalists and the medical team there in the hospital take care of you a little better that way, because we're really familiar with you and what your needs are. And they may change, in the inpatient side, and we talk through a lot of, acute things in the hospital, things that happen that you're not planning on. Like, I'm in the hospital because I have pneumonia, and, will I need, rehab when I get out, or will I need additional support, or, oxygen, or things like that. So we have those discussions too. Also, of course, our outpatient clinic that I talked mainly on, and then community-based or in the home long-term care facility. Next slide, please. Some of our community palliative support options here. Like I said, LMH does have a palliative support inpatient and outpatient. We also are able to see patients down in oncology. So if they are receiving treatments, we can go down there and do our visit down there. So it kind of minimizes having to do multiple visits, but also we're keeping an eye on them and helping with their symptoms while they're receiving treatment. If anything should come up that we need to talk about, whether the symptoms are related to the cancer itself or the treatments that may cause those additional symptoms, we kind of help with our oncologists to manage those. Also, the Kansas Palliative and Hospice Care, I do know they do see patients in our community at home in the surrounding, I think, in the surrounding counties. And soon VNA will be adding a community-based and home-based palliative care program in addition to their other service lines, which is home health and hospice, to help just kind of fill that little gap for patients that can't maybe get to the clinic or have a hard time. It really takes a lot out of them to get out of the house to appointments, to go see them in their home, just to add that extra layer of support and maybe make some medication changes for symptoms if we need to. Try to help keep them out of the hospital, keeping them home more and making those adjustments as needed. So next page. Do have some online resources. These are a few that I used for some of my information today that I included in this presentation. National Hospice and Palliative Care Association organization. They have the caringinfo.org with a lot of additional information that I've talked about today. So that's a really good tool to kind of go to and look up more information. Also the World Health Organization, who we have heard a lot about, I'm sure, over the last few years in the news, and they are always a good website to go to for any sort of topics. And they also have a palliative side, so they have a good website there for information. And then LMH website that is full of community resources, also advanced care planning resources too. So if you get on there, the care coordination, you can, get blank advanced care planning documents like the durable power of attorney or living will, and print those off, and you can get those notarized at your bank or whatnot. So that's a good place to get those documents if you're looking to get those completed. You don't necessarily have to go to a lawyer to do that. Next slide, please. So takeaways. One thing is, I thought I put questions in here. I am sorry. One thing is complete your advance directives. A lot of times when patients come in the hospital, they've not talked about, what their wishes would be, or maybe who would make decisions for them if they're not able to. And then we're kind of scrambling. And then, the loved ones are like, well, gosh, I've never had this discussion with my mom or my dad. I don't know what they'd want. And so that almost puts more stress on them if you went ahead and have that discussion before crisis occurs. So my advice is just to get those completed and maybe talk with them about what you'd want, or how you envision, your care to go if things weren't going well, and how you would want to be supported at that time. I said, why do people not talk about these things? Because it's hard. It's very hard to talk about it and bring it up. Nobody wants to talk about end of life or what happens if I get really sick. But please take the time to do so. You'll be glad you did. And then spread the word. That's why we do these educations, to, get more awareness out about the support of hospice, or support of hospice, palliative care, and hospice, but what palliative care is, and how we can help, because it is a good, I believe, support in our healthcare system, and alongside with your other care. I think that should be it. Maybe next slide.
Is this a good time for a couple quick questions?
Yep, that's where I put that question.
That's it.
Slide.
Okay.
I meant to put one in the middle to give me a break too, but
Okay.
I apologize.
We have, before we move on to the other side of this, the other half of this, there were a couple questions in the chat. One of them was, who calls in palliative care? Is it the doctor, the patient, the family, the hospital? Who makes that decision, or any or all of them?
That's a very good question. So, if you're on the outpatient side, if you go see your primary care doctor, or if you're seeing like pulmonology or oncology or any of those specialists, you can ask them, hey, do you think it'd be good for me to see palliative care? And, some of our providers, even today, they don't really fully understand what palliative care is. And you may need to say, well, it's not hospice, or just call our office, we take self-referrals too. And I'm not sure about other, I know Topeka, Stormont has a palliative care program as well as the inpatient, outpatient side. I'm not sure, how they work, but, you could call our office or even call any palliative care office and say, hey, I think I'd like to see you. How do I go about doing that? But so we take self-referrals. We also, get a lot from primary care providers, just saying, hey, things are getting hard. I think they benefit from another level of support and layer of support, or just the specialists like, our lung doctors or our oncologists, if, they're having a lot of symptoms and breathlessness with their COPD and, having a hard time getting in the shower and things like that. They'll send them to us and say, hey, they need just some help with some symptom management and they need to be able to breathe a little easier. We have some tools for that and medications that we can try just to help you get through the day. So the long answer to that question is really anybody, but just bringing it up with your primary care provider or any of your doctors and say, hey, do you know about palliative care? I think I'd like to be able to see them. And if you don't get any response through that, just call the office and talk to them directly. And then they can go through the avenues of reaching out to your doctor and saying, hey, I think that they would like to see us and go from that way. But inpatient side, that usually it's up to kind of the doctors. But if a family member comes in and says, hey, I think we need palliative care, they are usually open to consulting us, especially if somebody requests it.
One of the other one of the other ones now is, does insurance or Medicare cover palliative care?
Yes, generally.
Okay.
Generally, all the insurances will cover our visits. It just depends on the insurance. It depends on whether you'll have a copay or not for any of your other visits too.
I'll do a quick side question to go with the last question. Is that dependent on whether the doctor requested or the patient requested? Would that make a difference in the insurance?
Well, and we look at that. That actually just came up this week because I had a self-referral and, certain insurances like the commercial insurances, not necessarily, I don't think we've run into a problem with Medicare per se, but commercial insurances sometimes will require a referral through a doctor in order for you to see us. And that's okay. Well, we can just get, if you do call in, we can just reach out to your primary care provider, tell them, what you've requested to see us and maybe why. And generally they are more than happy to write that referral. But okay, we double check on that because we don't want you to be caught with anything. Yeah. Any surprises there.
One other question that came up is, do people ever get off of palliative care as their health improves, or is it kind of used in the sense of it's, an end of life care?
People do, yeah. So we just look at us as like another, so you have your cardiologists, you have your pulmonologists, you have your kidney doctors. Just look at it as another specialty. Your obstetrics, your OB doctors. We're really just another specialty, but we had just a different focus. And so it's not that we may discharge somebody, like hospice may discharge somebody if they improve, right? We just may see patients so some of my patients I'll see weekly if I'm titrating medications. So if we're addressing some pain that's getting worse and we need to make adjustments, I'll see you weekly. And sometimes we'll do telehealth as well to make those adjustments because we want to make sure that you're tolerating the medications also if it's working. Some of them I see, every month or maybe every 3 months, every 6 months. So it's really just, how they're doing and just always really being there. I don't necessarily say I maybe if some patients say, I feel like I'm doing fine. I don't necessarily want to see see you in, 6 months. We may just do a phone call in 6 months to see how you're doing. But we're always there. So, even if we don't see you for a time and you call and you're like, gosh, things have changed with my health and I really like to get in and talk to you again. And by all means, welcome back. So we don't have structured follow-ups. It's just really based on how you're doing.
Okay. I think rather, I didn't see anything else, but I think to allow fair time, we should move on to the rest of the presentation, and then we can pick up any additional questions at the end for anybody who if I've missed one somewhere.
That sounds great. Thank you.
Good afternoon. I am Debbie with Douglas County Visiting Nurses Hospice. I am the hospice manager. Let's see, first slide, please.
I think.
Is that the one you wanted?
Yes, thank you.
Okay.
The belief that each of us has the right to die pain-free and with dignity, and that our families will receive the necessary support to do so. So hospice and palliative care do really have the same philosophy. We usually get the same hospice referrals that palliative gets, but they are more end stage when they come to hospice. End stage CHF, cancer, Alzheimer's, lung disease, HIV, ALS, Parkinson's. So basically the same diagnoses that palliative care also sees. If a patient is declining and not doing well, losing weight, difficulty swallowing, decreased appetite, doesn't want to go back into the hospital, please call us for an informational and we can come out and do an assessment. And if you're not eligible for hospice, we can at least talk about other resources in the community to help you. Next slide, please. Like palliative also provides, we provide an extra layer of support. Hospice care is a holistic team approach to specialized medical care, just as in palliative is. We improve the quality of life through pain and symptom management while providing emotional and spiritual support to patients and their loved ones facing a limited illness. We recognize dying as a part of the normal process of living. Hospice affirms life and it neither hastens or postpones death. Unfortunately, hospice is underutilized, and in many cases we get referrals when someone is in crisis, very ill, symptoms are out of control, and family is very stressed. It would be great if patients and families are thinking about hospice to call us and we can come out and assess the situation and make recommendations. Next slide, please. Okay.
Is that the right one?
Yes, it is.
Okay.
The admission criteria for hospice: physician certifies life-limiting illness, prognosis is less than 6 months. 6 months is really an educated guess. A lot of times our patients live a lot longer than 6 months, sometimes a little less, but as long as they are needing our services and they are declining, we will keep them on service. We do have some patients that have been on hospice for over a year and they still are declining and require our services. So as long as we can show the documentation of decline, we're fine to stay in. Patients and family choose the hospice philosophy, goals of comfort rather than curative treatment. So unlike palliative, you cannot be receiving curative treatments, radiation, chemotherapy, dialysis, because we are end-of-life care. VNA, we also see patients within a 25-mile radius, so we have a good response time for our patients. We see all of Douglas County, Eudora, DeSoto, Baldwin, Ottawa, Perry. We see the outskirts of Douglas County. We generally prefer if a patient had a primary caregiver available in the home to care for the patient, but that's not always the case. So we have social workers, and with the team, we will start working on options for that patient. So everything is in place when they need more care. Also for hospice, you do not need a DNR, which is a do not resuscitate. Next slide, please. So here's our hospice team. It's our physician. It's physician directed. We meet weekly with our medical director, who is Dr. Szynski. We discuss all of our patients and the problems we're having. We also have a pharmacist that attends meetings so she can review all medications. Occasionally we have a patient who will move to Lawrence so they could live with a family member, and if they don't have a physician, Dr. Szynski will assume care. We have a dietitian over at LMH. We contract with a dietitian there. Our nurses are the case managers. We develop with the team individualized plan of care based on patient and family preferences and needs. We continuously educate families on their disease process, medications, when they need equipment, and just providing care as the patient declines. Our visits, usually a nurse will come out 2 to 3 times a week initially, and increase visits as needed, as with all of our team members. We have aides that provide personal care and bathing, therapists. Occasionally somebody wants some occupational therapy or physical therapy to so they can continue their strength. And we have a therapist come in and develop a home exercise program, and we can work with them with that. Social workers help with the end-of-life preparation, funeral planning, and advanced directives. We have spiritual and bereavement counselors. We have a chaplain, an interfaith chaplain, and he also provides bereavement for 13 months after the death of a family of a patient, and he will do bereavement for family members and friends if requested. We have a volunteer program, which is led by Sarah Rooney, who is continuously seeking out volunteers for our program. So if you're interested in volunteering, please call us. They do respite, massages, companionship, music therapy, canines. We have 2 dogs that go out to the facilities. And we also have a doula program, which is certified for end-of-life care. And our services are all 24/7. So in the middle of the night, if you need anything, have any questions, you can call anytime and we can come out to make a visit. Next slide, please. And it's, what does our hospice cover? All of our visits are covered. We cover all of the medications related to the primary diagnosis that you are admitted with. So if you're admitted with congestive heart failure, we cover all your cardiac meds. If you're admitted with end-stage lung disease, we would cover all of your inhalers. We cover all symptom medications for pain, anxiety, bowel management. And people kind of worry that we're not going to cover their other meds, but usually their Medicare Part D will cover those meds. We cover all durable medical equipment. We have a company that usually can have the equipment in the home within 2 hours. Hospital bed, shower chair, wheelchair, bedside commode, whatever you need. Our services are covered by Medicare Part A. We take Medicaid and most private insurances. Unfortunately, some of our within private insurances and our younger clients, they might not have a hospice policy, but we do have, we do charity care. We want everyone to have hospice if they want it. Next slide, please. I think the takeaway from hospice is that we, like palliative, promote quality of life, symptom management. We are available 24/7. We have charity care so everyone can get hospice if they want. We prepare patients and family for a peaceful death, and we continue to support the family after the death of their loved one. Any questions?
I don't see any yet in the chat, but let me pose one question. You talked about
Sure.
medication. Is
Yes.
there a cutoff in the medication, a distinction between say pain medication and curative medication? And how is that? Because you did talk about blood pressure medicine and other medicines.
Right.
You don't have to give those up to be on hospice care?
No,
okay.
no, not at all.
So is there a distinction where you draw the medication line?
No, so we will, usually all of those meds for their other diagnoses will still be covered by their Medicare Part D. And if there is a problem, they can call us and we can work things out with them. But usually we cover most of the medications. If the medications we don't cover would be oral chemotherapy or anything like that.
Okay, understand. All right, anybody else have any questions? Nothing else in the chat? I did have one other question. You mentioned in hospice, animal therapy, music therapy, those concepts. In palliative care, is that also included, or is that not considered? And I know you have the screen, Debbie, but is that part of that?
Hi.
Thank you.
So it's not part of it, but I always explore those things that our patients enjoy and try to find resources for them, like support groups or community-based programs that may benefit them and involve them or get them out of the house, be able to find things they enjoy. So it's not included, but we definitely look to find those resources and how we can get in touch with those resources for you.
Terrific.
Yeah.
Okay, thanks. There is a question just popped up, and this is, I think, a very interesting and important one. If, for whatever reason, a patient seeks help in hastening their death, can advice be given?
We treat the patient for their pain management, and we increase their pain management as they need it. We're just here to keep them comfortable. We do not hasten.
Okay.
And let me let Ashley speak.
Yeah, is the question directed to those, what are those called? Like, thank you. Like the active euthanasia that are legal in some states?
I can only read the question here, and I don't know if the person who asked wants to get on and speak for themselves with that. And if you do, you can. You don't have to. But I think that what they're talking about is there any coverage for hastening death as opposed to, or being taken off of meds or whatever it is that's part of the hospice care?
So if this question is at the very end of, can you put that back up again? At the very end of life, if their symptoms aren't controlled at home, we can always have them go over to the hospital inpatient symptom management, and the team over there can help them. And we can do IV meds over there and control their symptoms, get their symptoms under control.
Okay. So it's all controlled. Okay. I think you've answered the question. I don't want to push you into a corner. So I think you've answered the question.
Okay. Yes.
The other, this is a similar question that came in at the very end of life when pain relief isn't working. Is there a policy of something like induced unconsciousness?
Yes. I'll let Ashley go ahead.
Okay.
Yeah, we do. Oh, excuse me.
You're fine.
We do. In rare occasions, do a continuous infusion or kind of palliative sedation, if you will, if we have tried everything and we cannot get the symptoms under control.
Okay.
And it is situational. Typically we can get symptoms under control, but if we're seeing that we're needing round the clock medicine and the nurses are kind of going in there and giving medicine, every hour, every 30 minutes, then we will go ahead and start a continuous infusion. But like, again, not so to hasten death, it's just the fact that they're needing more and more around the clock medications. And so in order to give them the best relief, we put that into like a controlled pump in order for them to get those continuously. So
okay, let me switch over to a different subject here. One of the questions is, do you need to be housebound to receive hospice?
No, you do not have to be homebound.
Okay. So I think the other questions also lead to what Ashley brought up earlier about the DNRs and about the family truly understanding what your wishes are is part of, I think, the answer to some of those earlier questions, so that family decisions can be made as well. So I'm putting words in your mouth. I apologize for that, but
That's
it
okay.
seems like that I think that might be part of it. Okay, any other questions, anyone else? We still have a little bit more time.
Yes. Is hospice more of a service, or is it also a place? Because I had an impression that there were hospice places where people could go for care
Right.
at the end of life.
So we see people in their homes, and there is a hospice house in Olathe and one in Topeka. So somebody can have a referral to those places if that's what they want. But usually it's a service.
Okay. Any other questions? Well, I think that kind of sums it up. I really want to thank both of our participants today. I think we got a lot of good information, and obviously there were some questions that this kind of helped, I think, solidify some understanding. So thank you, both of you, Ashley and Debbie, for participating. We really appreciate it.
I want to add one thing. You know, if any questions come up, I know that my nurses over there at LMH Palliative would be happy to answer any questions on the phone. They're answering our phones Monday through Friday. And if you have any questions directed towards hospice, I know that they would probably be more than happy to answer those questions if you had any come up. So
are you comfortable with us sharing your slides with the group?
Yeah.
Yes.
Is that all right?
Okay. I'm fine with my end.
Yes, that's fine.
Okay, that's great. We appreciate that. Well, I think speaking for everyone, I want to thank both of you for participating tonight. If you would like to unmute or just show your applause, we can show our appreciation for the participation. I do want to remind you again that we will not be having Gray Anatomy for the next few months. We'll start again in September, and hopefully with some of the ideas that you guys forwarded to us. I want to thank Allison from LMH as well for putting all of this program together and continuing to do this in the future for us. It's been tremendously informative generally for everybody who's participated. Anything you'd like to add, Kathleen, before I close it off?
On another topic, for if you're looking for anything to do tonight, come to the summer reading kickoff party from 6 to 8 on the library lawn. There's be a Beatles cover band and tacos and beer and free snow cones, so you can't beat that.
Yeah, sounds fun.
There's my library pitch.